Good afternoon. Please grab a seat and join us in the celebration. I'm Dr. John Kobashigawa, Director of the Cedars-Sinai Heart Transplant Program, and with me is Dr. Leon Fine, who is Chair of the Biomedical and History of Medicine Program here at Cedars-Sinai. It's a pleasure for us to welcome all of you to this 50th anniversary celebration of the first human heart transplant done by Dr. Christian Barnard 50 years ago plus in December 1967. So how many of you out there remember the first human heart transplant? Oh my God, a lot of oldies but goodies here. Leon, I thought we were the only two that remember this. Anyway, it's great to have you here today. And it's also a celebration of our first human heart transplant performed here at Cedars-Sinai in 1988. It's just a few years after 1967 when that first transplant was done. And we'll have people recall those moments when we had our first human heart transplant here. So without further ado, I'd like to introduce Dr. Fine, who will introduce our guests and we'll get our program underway. Again, welcome for everyone to attend.
Good afternoon. At 9 o'clock in the morning, on a Sunday morning, on the 3rd of December, I opened the New York Times and I saw that this was the 50th anniversary of the first heart transplant ever done. I picked up the phone to one of the speakers who's here today and I said, Warwick, you were there. When did the transplant end? And he said, about 10 o'clock in the morning. I said, at 1 minute past 10, our celebration of the 50th anniversary has started. It will go on for a few months till we can find a venue and we can get our speakers together, but this is the grand finale of the 50th anniversary. So it's a great pleasure to have you here. One of the unique opportunities we have is that three of us were medical students in graduating in 1966 from the University of Cape Town. I happened to leave South Africa within a month of graduating. Our first two speakers were interns at the Groote Schuur Hospital. By the way, when you leave the hall today, you have to be able to say Groote Schuur Hospital. And and they were interns in those days and were involved in some way or other with the first and indeed the second heart transplants ever done. So it's a great pleasure to welcome the two of them. I think what I'm going to do is introduce both of them and then let them come up sequentially. So our first speaker today is Dr. Warwick Peacock, who is a professor of surgery at UCLA, one of the world's eminent pediatric neurosurgeons, who trained originally in Cape Town, believe it or not, went into general practice, then returned to, he trained subsequently in Edinburgh and Toronto, came back to Cape Town, where he was the lead pediatric neurosurgeon in what then was the Red Cross Hospital, which was the preeminent children's hospital of the day. And at that hospital, he developed neurosurgical techniques for the treatment of spasticity in children with cerebral palsy. For children with intractable epilepsy, he developed innovative surgical techniques, and his methods and techniques have become adopted worldwide. He then arrived at UCLA, where he headed up the pediatric neurosurgery program. After a number of years, left to become head of neurosurgery at UCSF, and returned. All okay there? And then returned to UCLA after having completed and retired as a neurosurgeon to come back to his original passion, which was anatomy. And today he teaches surgical anatomy in a special lab. I think he's called the Director of Surgical Research, and has a very creative anatomy teaching program. Our second guest is Desmond Shapiro. Desmond Shapiro, too, was a classmate of mine. He was wise enough also to become a nephrologist, trained in nephrology at the Hammersmith Hospital briefly, came back to the University of Cape Town to the Groote Schuur Hospital, where he did some of his early nephrology training, and then made his way out to Los Angeles, where he did a fellowship in nephrology at the Wadsworth VA Hospital, which was then really the preeminent nephrology training program. He moved up to Santa Rosa, where he built a very substantial nephrology practice. He was linked and has constantly worked at the Santa Rosa Memorial Hospital. He started the first dialysis program there and the first transplant program, renal transplant program in that part of the world. Just recently he stepped down, and his particular passion at the moment is patient safety. And he continues to serve the board of the Santa Rosa Memorial Hospital as an advisor in that critical area. So these are our first two speakers. I'm going to call Warwick up first, and he'll be followed by Des Shapiro, and thereafter John Kabashigawa will take over and introduce all that happened subsequently. So welcome and very good to have you.
Well, thank you very much indeed for inviting me to be here. I was the intern at the time of the heart transplant in Cape Town, and when Leon asked me to give the talk, it was going to be about 30 minutes, but he informed me just before the last weekend, it was now 9 minutes. So put on your seatbelts, we're going to get through this in 9 minutes. Christiaan Barnard was a fantastic guy, but he was remembered essentially because he did the first heart transplant, and also because of his flamboyant lifestyle with famous ladies in Europe. He had countless affairs, and those are the things that he's known for. But I'd like to show you that there was a lot more to this guy than that. He was born in Beaufort West in 1922, one of the four sons of a dominee with the Dutch Reformed Church. They were very poor, and he was known as the barefoot boy from Beaufort West. They would go to school barefoot. And that's the little town, if I can get the right, yeah, that's the little town there. There's Cape Town, and Johannesburg's up here somewhere, and this is the church of the Dutch Reformed Church. In 1945, he got into medical school at the University of Cape Town, and this is the university on the side of Table Mountain, Devil's Peak, and here is the hospital, this beautiful hospital, Groote Schuur Hospital, as Leon will be testing you at the end. He graduated in 1945, and he did as I did. He went out into general practice in this beautiful little town, Ceres, here it is, where they did everything. Operated on the patients, delivered the babies, house calls, and he had a tremendous experience there, but he was determined to make some more definite contributions to medicine. So he went back to Cape Town, and one of the terrible conditions that we had to treat was tuberculous meningitis. Kids either died from it, developed hydrocephalus, or developed multiple infarcts, and there is what it looks like, this basal meningitis, hydrocephalus, infarcts, and he came up with a number of ways of treating it differently using intrathecal steroids, and dropped the mortality rate and the morbidity rate tremendously. That was his first PhD. He had 2 PhDs. This is his second PhD. Children born with intestinal atresia would be vomiting, and then eventually a diagnosis would be made of this narrowing in the bowel. And he operated on little puppies in utero, ligated a branch of the superior mesenteric artery, and when the pups were born, they had intestinal atresia. And he showed that just by resecting that atresia, you weren't treating the condition, because all this bowel on either side of it was abnormal, and you had to resect some, and when you put it together, it would heal. And instead of an 80% mortality rate, it was down to about 10%. He also got a degree for his work on aortic valve replacement, and this is the valve that he designed, which was built by the South African Railways at the Railways Engineering Shop in Salt River. And it worked very well, but it's become a little more sophisticated since then. He went to the University of Minnesota, where he worked with Walt Lillehei, who developed the heart-lung machine. And that's Walt Lillehei there with this rather fearsome headlight, which if he turned in your eyes would completely blind you. But he was one of the great guys in the story of cardiac surgery. He also went to Pittsburgh because he had now become interested in transplantation. And so he went to see Tom Starzl in Pittsburgh, who did the liver transplantation, and he went to visit David Hume and Richard Lauer at the Medical College of Virginia to see what they were doing with their transplantation. Now, this is the story. I was the intern at the hospital at the time, looking after Louis Washkansky in the D1 ward. He'd had 3 myocardial infarcts and was brought in by Vel Schreier, the cardiologist. He'd drawn up a list of 10 patients who he felt were terminal and would be candidates for a heart transplant. And he was put in the D-floor ICU. He came in September and just waiting for a donor. And then on Saturday afternoon, December the 2nd, Denise Darville was going with her mother to the store to buy some cookies at this Wrench Bakery here on the main road in Observatory, and she was struck by a car. Her mother was killed outright. She was taken to Chirurgia Hospital, where Peter Rosinis, one of the senior neurosurgeons, considered her brain dead. And so the cardiac surgery team were informed. They had this patient dying in the ward, Louis Washkansky. They had this young woman with a perfect heart, and here was the perfect situation. So at 1 a.m. on the 3rd of December, Louis Washkansky was brought in to the B-floor operating room, and Denise Darville was in the room adjacent. Marius Barnard, who was Chris's younger brother, was also a cardiac surgeon, and he removed Denise Darville's heart and brought it through where Chris Barnard actually did the transplant in Chirurgia Hospital, this beautiful hospital on the B floor on December the 3rd. And I'm sorry to say, Leon, they didn't take until 10. They finished at 6 o'clock in the morning, a 5-hour procedure. And so it was successful, and it just hit the world. It was on the front page of all the newspapers around the world. And this is what it looked like outside Chirurgia Hospital, with all these patients clamoring to see Chris Barnard. But, and this here, I was standing behind the cameras when they took this picture, and I see it's on the wall there. I wasn't allowed, I was an intern. You stand over there. But the only person you can see here who is really at ease was Chris Barnard. The others were all standing at attention. There's Vel Schreier, the wonderful cardiologist. And these nurses, when I was intern, they all looked so old. But when I look at them now, they're really young. They were much too old for me in those days. But a few days later, Louis Washkansky started deteriorating, and Chris Barnard saw these arrhythmias that he was developing and interpreted them as being rejection. So he was on Imuran, the immunosuppressive drug, but he was taken down to J Block to have radiation therapy because of this imagined rejection. And on the 18th day, he died of pneumonia. So the treatment they gave was completely wrong. And there's Marius and MC Buerta at the funeral, and Chris Barnard was absolutely devastated. But it didn't take very long. Lying in the ward where we were, the D-floor cardiac ICU, was Philip Bleiberg. He was a dentist and had multiple infarcts and was waiting for a transplant. And then on January the 1st, I just happened to be the intern on call that day for the emergency room, and I was called to see this young man. He's only been married 3 months. This is his wedding photograph. He'd been playing beach ball on the beach and suddenly had a massive intracranial hemorrhage and was brought in and was declared, well, I was asked to see him. And I found no spontaneous movement. He was on a Bird ventilator, if you can remember those old days, the Bird ventilator. And no response to painful stimuli, fixed dilated pupils. But you had to have been qualified for 5 years in South Africa to be able to declare someone brain dead. So I called in, and anybody who was at Groote Hospital would know this person, Bill Hoffenberg, who later became Sir Raymond Hoffenberg and the president of the Royal College of Physicians. He came in and he examined him, but he said, no, we can't declare him brain dead. We have to wait until the morning. So on the 2nd of January, the heart transplant was done, and there is Philip Bleiberg. There he is in October. The dates are changed in South Africa. It's 4th of October. And here he is. And he lived for 18 months. I just found a few of the transplants that he did. Chris Barnard did. The third one lived for 20 months, the fifth one for 12 years, and the sixth patient lived for 23 years. So in my 9 minutes, I just wanted to show you that he wasn't just a playboy. He wasn't just the guy who did the first heart transplant. He had 2 PhDs. He did a lot in medicine. He was very controversial, but he was a charming man if you didn't get on the wrong side of him. And brilliant medical research in a number of fields, and a very bold surgeon. I think that's 9 minutes.
Good morning, good afternoon. Thank you very much. What a pleasure and a lot of fun. And thank you, Leon, for putting it on and for helping jog my memory for really an amazing past. The introduction was lacking for one thing. My major claim to fame is that I taught Leon everything he knows. So a little sense of Cape Town at the time. So it's it was an English colony. Kennedy was assassinated in 1962. It was by law a racist country. The races were segregated by law and kept apart by law, including in the hospital. And the system was the old British system. You went to medical school from high school, and it was 6 years. So I went to medical school when I was 16, and I graduated when I was 21, and I was an intern when I was 22. When you became a doctor there, you became a doctor because you wanted to help people. You never even thought about anything else or money or anything. Everybody got paid the same. The professor of history was paid the same as Professor Barnard. And it was basically an environment of, if you had a problem, you would try and solve it. And it was an incredibly experience because we had first world skills and a third world patient population. So a place like Groote Hospital, at the same time of doing a heart transplant, on the other wards you'd have an amoebic pericarditis, a parasitic abscess of the brain, people dying of TB, a lot of the parasitic diseases, and it was just an incredible contrast. Oh, tetanus, we would have ICUs full of tetanus. Bernard Launer just brought out the first criteria for myocardial infarction, so it was just at the start of ICUs for heart disease, heart attacks. So, so the sense of it is that there were problems to be solved, and people wanted to solve them. My role was I actually would follow around the nephrologist whose name was Jeff Thatcher. And the style of it was that, of the transplant for Washkansky, was that all the specialists from all the specialties, the professor would round. He insisted that the professor would round. So I would schlep behind my professor, and being an intern, basically making sure he didn't drop anything, or if he did, pick it up for him. That was my role. Or maybe take some bloods down to the lab. But like the bacteriology was done by the professor of bacteriology. He would take the swabs, he would go down, he would make sure what was happening. A visual that I would share with you is that, so we'd be a long corridor, there'd be a handrail, and the wash basin to get into the room was those old enamel basins in a 3-legged stand. something you'd buy now in an antique store and be proud to own it. You know, the chips of enamel out of it. There'd be a towel draped over the thing and some Lifebuoy soap, and you'd wash your hands before you go in, and everybody would use the same towel. Notwithstanding, they were incredibly alert for infection. They had those rooms scrubbed every day. The beds were scrubbed. They were very much alert to infection. What we didn't have, and I don't have to tell you, we did not have ultrasound. We had chest x-ray. We had brilliant clinicians. This was the days when Val Schwerer, they would go to open heart surgery based on Val Schwerer's clinical exam. When we examined patients in those days, cardiac patients, we'd figure out how big the left ventricle was, how big the right ventricle was. We'd be auscultating and palpating for left atrium. We'd be listening to the second heart sound to try and see how much pulmonary hypertension there was. Was it single? Was it reverse split? If it's reverse split, that's really high hypertension, correct? Looking at the V waves of the neck veins. If there's V waves, it's tricuspid incompetence, we're getting into trouble. You're talking minutiae, but that's all we had. Val Schwerer would examine a patient and be dictating at the same time all these details. What estimated pulmonary artery pressure, this, that, and the other. We had no Swan-Ganz catheters, we had central venous lines. Our surrogate marker for left atrial pressure was Curly lines. We were fanatic Curly line lookers. Are they A's, are they B's? You know what I'm talking about. It's what we had, but it helped. So Washkansky was actually a very poor candidate for transplant because he had cellulitis of the ankles and with active infection. And as you know, nobody would transplant anybody like that. And he had Southey's tubes in there, which was a physical way of draining edema. The best diuretic we had was Mercilil, was the only parenteral diuretic, intravenous mercury. And we had Thiazaz and one other, I think. So very difficult to get a brisk diuresis. What we also had, we had only bird ventilators. Now, imagine this running an ICU on a bird ventilator in a modern setting. You got 40% maximum oxygen, 40%, and you got no volume regulation. Pure pressure. And the thing was, anytime you would go by a bird, you'd give it a little nudge to give it a nice big breath. That was your peep, and that's the best you could do, give a big push. But not too much of a push because you didn't want to cause a pneumothorax. All pressure monitored. The other thing we had was we did not have telemetry. So you had this huge old EKG hooked up to the patient with this big old, and then it's time to move it. It's be like sort of running and getting, okay, do you think we've got time now? Okay, let's go. Disconnect, and then reconnect at the other end. I mean, hair-raising stuff. And this guy, actually, Washkansky, because of his cellulitis, was taken down for cobalt for his cellulitis as well, which is pretty unusual. They're trying to treat it. So he would go down, say, be disconnected from monitors, go down. So the poor man had a very hard time, actually. He had probably 3 or 4 good days. We would go in every day, and I'd write some notes. But he got progressively more edematous. And we didn't have O2 sat, by the way. So you'd have we'd pull the O2 out of a radial artery and do an astrop. Remember the old astrop? And you get a PO2 out of it. And so, and that would only last so long, and you'd have to take it out. And then to do a blood gas, you'd have to stick the artery every time, so it was a big deal. And so he was getting progressively hypoxic, and the only way to increase the PO2 was to handbag him. So there were guys taking turns giving handbag to get higher oxygen. And Barnard had actually come to the States to learn about transplant in a renal program, David Hume's program, and it actually did his first kidney transplant on one of my patients so that he could learn. And he had somehow got stuck on this idea of transplant lung, which I think was more a bone marrow issue, where you auto-reject your own lung. And as Washkansky got worse and worse, Barnard convinced everybody to increase the immunosuppression. And at the end, the guy was on actinomycin, and you could just name it. He was like a leukemia patient. And that's basically what killed him. And Barnard was actually very upset about it, obviously. But Washkansky had an autopsy the next day, and Barnard realized what he'd done. Because the guy basically had empyemas, bilateral empyemas by now. And he realized what he'd done, and he said, you know what, I think we made a mistake. We did much too much immunosuppression. He was already ready not to do Bleiberg, apparently, from what I remember. But once he got rejuvenated by seeing that they could have changed course, he went and he spoke to Bleiberg and said, look, we're going to do it differently this time. Are you still up for it? So that gives you a little sense of the can-do attitude and what was going on. And yeah, if there's any questions, I'll take them. But thank you, and enjoy.
Well, thank you so much, Warwick and Des, for taking us back to those days. A lot of trials and tribulations at that time. Obviously, we didn't quite know what we were doing. I think we still know what we're doing now, but a little bit better now than before. You know, I'd like to call up Dr. Trento. Ah, there he is, Dr. Alfredo Trento. You know, it's by coincidence, it is this year, 30 years ago, that the Cedars-Sinai Heart Transplant Program began under the illustrious career of Dr. Trento. And Dr. Trento is very modest, but he actually championed the new bicaval technique, the way we do heart transplantations today. Fredo, take us back to those days.
All right. Well, I came to Cedars in October 1988, and my task was to start a pediatric cardiac surgery program and a heart transplant program. I had been at the University of Pittsburgh for 6 years, and coincidentally, this year is the 5th anniversary of the first heart transplant in Pittsburgh. My mentor, Dr. Henry Bunson, performed in August of '68, and the patient survived 14 months. We all know then what happened to transplantation. From then, the '68 was the year where everybody in the US, every big surgeon tried to do them, and then the outcomes were not good, less than 50% 1-year survival. So the enthusiasm went down, and only Stanford really continued through the '70s. And then the introduction of cyclosporine really made the difference. So when I went to Pittsburgh in January of '83, the transplant program was strong already. Starzl had gone there in 1978, and he really brought cyclosporine with him and the experience of using it, a new drug. And this was our Bible, this issue on current problems of surgery that came out of Stanford, Norman Shamway, who really did with all the dog work on transplantation, and Christian Barnard learned, and he did have the merit to do the first one. And Stanford was really almost ready to do the first one. They didn't have the gut. And as soon as Christian did it, then everybody followed. So heart transplantation was very glamorous. Going to procure a heart was glamorous. These are the corporations that had their headquarters in Pittsburgh. We were using their jets, Westinghouse and Alcoa, US Steel. And we will go to a little town, and we will be on the paper the next day of a team going and get a transplant, and we'll show you with the little ice chest and so forth. There is no glamour anymore in going to procure a heart. I have to make 10 phone calls and beg surgeons to do it. So, but that's what happened in Pittsburgh as far as the activity. You see, in 1980, in 1980, when I got there in 1982, 83, they did 20 transplants, but then by 1984, they were already over 40, And in 1986, we did almost 100. So it was an incredible exponential growth. And when I went there in 1983, there were only 4 centers in the US doing transplantation. There was Stanford, Pittsburgh, Houston, and Virginia. So over a period of 6 years while I was there, from 4 centers, the number of transplants increased almost to 50. It was like a spread, but everything we did was new science. We were publishing everything that we did because nobody knew anything about it. And so it was a very fortunate time to be in transplantation. So what we learned, by 1988, we had a lot of information. And among the most important was this so-called age limit. When I first went there, the age limit was 55 because we thought that everybody else was too old. In fact, the survival, the 5-year survival for people younger and older than 55 was exactly the same. And also, we noticed that there was a difference in the outcome related to different genders. So as far as the 5 years being about the same for transplantation, look at the difference in the early outcome between female and males. The females had a significant drop in survival in the first year, and we really didn't know why. And then we were doing everything on our own. We would see the patient preoperatively, do the operative and postoperative follow-up, do the follow-up, do the biopsies ourselves, manage the immunosuppression. So we were everything. We were immunologists and we were pathologists. We would learn how to read the biopsy together with the pathologist because there was no experience. And we learned about necrosis and perivascular infiltrates and those things. So, and we learned also that patients would die suddenly, even in the operating room, because there were circulating antibodies. It was not only a humoral rejection, a cellular rejection, it was also a circulating antibody humoral rejection. And so we did studies and published among the first papers on this type of rejections. And so these were the cause of death. By 1988, you will see coronary artery disease. These are really, and infections were the main cause of death. Coronary artery disease obviously was chronic rejection, so that was the goal, to work on those two to improve the survival. So when I came to Pittsburgh, the division of cardiothoracic surgery was quite strong, directed by Dr. Madloff, and Dr. Shaw was the co-director. And in those years, most of the cases were coronary artery bypasses. We were doing up to 6 coronary artery bypasses a day in those 3 rooms that we still have. And here there are still some of the anesthesiologists present in those years. Dr. Errol Hackner and Arnie Friedman. I would like them to stand up because we want to recognize them. There are still some of the cardiac operating room nurses, Patsy Saud and Lisi. They are still, hopefully they are here, they are in the back. You see how young looking they still are, and I guess the hospital was practicing child labor in those years. So, and then we had a strong perfusion team. Ray, I see Ray Osborne here still, and he was directed by Dan McCabe, who came with Jack for the Brigham. So The first patient, and Dr. Caesar will talk a little more. So we came here, and we had UCLA had a strong heart transplant program started 5 years before by Dr. Lux. So it was the only transplant program in Southern California, so they were really strong, and basically also they could pick and choose, and they turned down this patient, 65-year-old, ischemic cardiomyopathy. She had recurrent ventricular tachycardia. So she was turned down because of age. So she came to see us, and basically I didn't see anything wrong with her otherwise, except for her heart, and I thought that she was an okay candidate. So we had a discussion, and she asked me, how many more years are you going to give me with a transplant? And based on our data, I said, well, I think you have a very good chance to live 5 more years. And she told me, I'm going to make you wrong, I'm going to live 20 more years. So when we did the procedure, obviously it was the first procedure. Nobody at Cedars had seen a heart transplantation before. So as far as creating a program, I came from Pittsburgh, where the program was in the hand of the surgeons. There were no cardiologists involved. There were 2 transplant coordinators. And then we used the help as needed, infectious disease, social worker, and so forth. So we had one meeting here before we did the procedure. I remember a room in one of those plaza-level rooms with long tables, and there were like 15, 20 people, and they were asking me, but what do you need? And I didn't know what to answer, you know? Well, we need an operating room, a patient, and and we'll go ahead and do it. And so these are the people that were around that day in the operating room. The anesthesiologist was Errol Ackner, and the nurses, they are not here anymore with us. Larry Caesar was picked as the cardiologist who was going to become the transplant cardiologist. And he learned on the job, and he has become a superb heart failure cardiologist. And our transplant coordinator, who was hired a month before, was Joanna Salamandra, that many of you know. So the transplant went very well. The patient did well, and she died at age 90. So then the heart transplant program flourished at Cedars. As John mentioned, we really pushed this technique in the US. We were the first users of bicaval anastomosis, and we published some important paper and gave presentation. We were doing about 30 transplants per year, so it was a small to moderate size program, but our outcomes was stupendous. Our 1-year survival was in general 100% every year. So then the program skyrocketed when John came with his group, and now it's flourishing very, very nicely. Thank you.
Thank you so much, Alfredo. Much of the success of the program truly was due to Dr. Trento and his amazing surgical colleagues who are here as well. I'd like to bring up Dr. Lawrence Caesar. Lawrence, come on up. Lawrence was our first cardiologist who put together the heart transplant program here at Cedars-Sinai. Much to do in terms of getting immunosuppression and complications under control. So Lawrence, tell us about those days.
Well, thank you, Dr. Kawashagawa, and all those responsible for putting together this event. It's truly an honor, and I consider myself lucky because I just got off the airplane last night from spending 10 days in Africa ministering medical needs to very, very poor, the poorest of the poor in Africa who have basically no access to care. Part of our team is still in flight because their plane got canceled, but I was able to come back. So thank you for this opportunity. And we're going to talk about our first patient who received a heart transplant at Cedars-Sinai. I went back to the original documents, and this patient was seen actually at Sharp Memorial in September of 1988. And as you can see here, the patient had a history of reactive airways disease, having had asthma, also was on bronchodilators, intermittently on steroids, presented with heart failure in February of 1988, and had an enlarged heart at that time. And although it was initially thought to be ischemic, coronary angiography showed normal coronaries, but very global hypokinesis. The main problem with the patient was recurrent episodes of cardiac arrest due to ventricular tachycardia. And for that, an AICD was placed, but the patient subsequently still had multiple episodes of defibrillator discharges due to VT, was taken care of by a prominent cardiologist and electrophysiologist here, Dr. William Mandel. And since February of '88, she had very advanced symptoms of heart failure, was unable to do household chores. She was initially sent to UCLA, believe it or not, and was seen by Lynn Warner Stevenson, a very good cardiologist there, was evaluated, but felt to have contraindications to transplant, including mild to moderate obesity, her reactive airways disease, and her age, being in the 60s. She did have a right heart catheterization that showed PA pressures in the 50s with a wedge of 20 and a cardiac output of 4 with a calculated PVR of around 3 Wood units, not 1 as shown here. PFTs were consistent with airways disease, and unfortunately, when she was started on bronchodilators to treat her airways disease, she developed ventricular tachycardia. She had an echocardiogram that showed an EF estimated to be 20%. LV end diastolic dimension was 80 millimeters or 8 centimeters with an end systolic dimension of 7 centimeters with severe mitral regurgitation and tricuspid insufficiency. So she had been admitted to Cedars-Sinai and then was transferred to Sharp Memorial for further evaluation after UCLA turned down the patient for consideration of heart transplantation. When she was examined, she had an S3 Gallop, and they did an endomyocardial biopsy, which showed no evidence of necrosis, no inflammatory infiltrate, no amyloid, no iron deposition. So this was truly an idiopathic dilated cardiomyopathy, no evidence of inflammatory disease or coronary disease. And she was seen by pulmonary, who did not consider her to have such severe airways disease that it was a contraindication to transplant. However, GI workup showed some evidence of diverticulosis, and endoscopy showed diverticulitis with some evidence of inflammation. However, indium scan was negative, CT scan was negative for abscess. Nevertheless, on the basis of that information, the patient was considered not a candidate for heart transplantation. As you can see here, kidney function was reasonable with a GFR around 67 mLs per minute, but the combination of her age, moderate obesity, reactive airways disease, and diverticulosis with evidence of diverticulitis, she was turned down also at Sharp Memorial. So she came back to Cedars, and with these diagnoses of recurrent ventricular arrhythmias, ICD implantation. During the workup, they did find heme-positive stools, presumably due to the diverticulitis, and the patient was seen here. And this is Dr. Trento's note from October 5th, 1988. The patient was 5 feet 7 inches, 175 pounds, blood type O. And it turns out that Robert Cass, one of the surgeons here, had put in her defibrillator, and by the time she came back here in October of '88, she had had 50 discharges of her defibrillator. It's noted here again that the PA pressures were elevated with a PVR of around 3, and upon further evaluation, it was noted that the patient had lost 25 pounds recently, was on a controlled diet of about 1,000 calories per day, and she thought that she would be able to lose another 20 pounds, so her obesity was not considered a contraindication to transplant. So, in contradistinction to the prior evaluations, it was felt here that the patient was a good candidate for transplant because on the basis of her intractable ventricular arrhythmias, recurrent discharges of her defibrillator, and by the way, no evidence of diverticulitis on our evaluation here. And although elevated pulmonary pressures were noted, we thought it was a manageable situation. So she was accepted for listing for transplantation. It was noted also that the patient was very much in favor of this, and we gave her a 6-year median survival and an operative risk of about 10%, which she accepted. So she was listed on November 3rd, 1988. The PRAs were negative. Her HLAs are shown there. And she was transplanted on December 22nd, 1988, with a 25-year-old donor gunshot wound to the head with an ischemic time of 107 minutes. And you can see the first biopsies, the first 12 biopsies are shown there, with one episode of moderate rejection in January of 1989, treated with Solumedrol. Otherwise, no or only mild episodes of rejection and normal coronaries 1 year after her transplant. Her immunosuppression early postoperatively consisted of induction therapy with OKT3 for 7 days, followed by cyclosporin, Imuran, and prednisone, which was 10 milligrams daily by the time of discharge. But because of her bronchospastic disease, she was on and off prednisone during much of the post-transplant course. Her later postoperative problems included not only asthma, but also eventually renal insufficiency and cardiac allograft vasculopathy, and underwent angioplasty with drug-eluting stent insertion in 2010, and did expire in 2011 after about 23 years. So I want to show
You're
what she
watching
looked like
Eyewitness News in high
at the
definition.
20th anniversary in
A
2008.
heartwarming story tonight about a local woman who has lived well beyond her doctor's expectations. Laurel Labash of Simi Valley was near death 20 years ago, but she became the very first heart transplant recipient at Cedars-Sinai Heart Institute. And today, the now 82-year-old went back to the hospital to celebrate another milestone. Denise Tador has the story.
She's a picture of health if you consider what 82-year-old Laura Labash has been through. She's survived 4 times longer than doctors predicted.
Dr. Trento promised me 5 years, and I said to him at the time, I'm going to make it 20.
Exactly. 2 decades later, she is celebrating being the first ever heart transplant patient at Cedars-Sinai's Heart and Lung Transplant Program.
She was at death's door basically 20 years ago.
Dr. Lawrence Caesar and Alfredo Trento agreed to do her transplant when other hospitals said no.
Really, patients over age 60 in those years were considered too old, and most of the time were turned down because we didn't know how they would react to transplantation and to immunosuppression and so forth.
Only half of heart transplant patients live 10 years out. And given Laurel's age and complications at the time of her transplant, the fact that she's here celebrating 20 years later is astounding. But doctors say it wasn't just luck.
And a great deal of it has to do with the skill of the surgeon and the skill of the team in taking care of these patients and maintaining them with proper medical care.
She and about 300 other transplant patients are celebrating the 20-year landmark. Since her transplant, Laurel has become a great-grandmother 12 times. But being able to see her 7 children grow up fills her with immense gratitude and pride.
I think I'm enjoying my children more than anything in the world.
So much, she'd like to stick around.
So you think you can go another 20? You never know. You never know.
In Los Angeles, Denise Tador, ABC 7 Eyewitness News.
Okay, so that's what transplant's all about. She got to see her grandchildren and her great-grandchildren and be with her family for a number of years until she finally expired, but of later complications. So I think that was a good start to our program. Thank you very much.
You know, truly, transplantation is a celebration of life, and that's why we do what we do. It's quite rewarding to see all these patients who are severely ill. I'd like to call up Dr. Fardad Ismailian. Dr. Ismailian is our surgical director of our transplant program. Just talk a little bit about our program, where we are today. So, Fardad, please.
Good afternoon, and thanks very much for inviting me to speak today. So as already mentioned on multiple occasions, our program started in 1988, and as of January of this year, we have done over 1,300 heart transplants, to be exact, 1,329 transplants. And since 2010, we have led the U.S. annual number of heart transplantation in adult transplantation, averaging more than 100 heart transplants per year. And our one-year survival has been over 90%, 91%, with outcomes surpassing government expectations. This is what we have done. We came here in 2010. John came in December of 2009, and I came in August of 2010. And as you can see, our program has really taken a logarithmic jump since then. And it's really been unprecedented that we have done over 100 transplants over the past 5 years. Even in our heydays at UCLA, we did, I think, 1 year we did over 100 transplants, and every other year was below that. So it's been a tremendous journey over the past 7 years, and we hope to continue the progress. Despite doing so many transplants, our survival and our government requirement graft survival has continued to be tremendous. The estimated probability of surviving a graft at 1 year in the US is over 90%. Ours is very much the same. And the one-year graft survival also continues to be significant, or close to 92%. And you have to understand that we get referral from all over the country currently. There's not one single week on a Friday morning where we have our selection committee where we get referrals from New York, from East Coast, New York, Boston, part of the northern part of the United States, like Oregon and Seattle, and all those people, centers that do transplantation, but they do send their patients to us because of the extreme high nature of their patients, and they want to take that risk, and they come to us for either because of surgical expertise or medical expertise in terms of how to manage their antibodies. Now, one of the problems with heart transplantation is obviously going to be the donor shortage. As you can see from this latest ISHLT graft, there are done about 4,000 heart transplants done in the northern United States. However, despite so many transplantations that are being done, we have a very paucity of organs. There are many patients that actually die on transplantation. Close to 20 to 30% of the patients die while they're on the waiting list, waiting for transplantation. So the problem of the donor shortage continues to be a major obstacle to progress of the heart transplantation. There are over 60% of the hearts that are actually unutilized currently in the United States. This is based on the study that was published not too long ago. And in California, actually the rate of the organ utilization has declined over the past few years, with slightly going up last year, and for a variety of reasons. So the question is how we can improve donor hearts and the number of donor hearts available. Mechanical circulatory supports, LVADs, and total artificial hearts and devices have been proposed as one of the solutions, try to help the patients with heart failure. But looking at the INTERMACS data, you can see that these are the patients who had some sort of mechanical circulatory support that were placed. And after 3 years, over 85% of them are going to have some kind of complications from mechanical circulatory support. So despite the advances in technology and improvement in the technology, there continues to be a problem with these devices as the ultimate goal in terms of treating these patients. And furthermore, we know that patients who are on wait lists and they have a status 1A, which is the highest priority in terms of transplantation goes, over 20 to 30% of them die, actually up to 70% die within 1 year while waiting on the wait list. So there's really a need to transplant patients, and mechanical support is not going to be the answer, at least at this point in time, maybe in the future. So one of the alternatives to donor shortage is use of DCD donors, the donation after cardiac death. And there are several categories of this donation DCD, and the one that's currently being proposed by different societies use what's called controlled DCD. That's when the donor whose life support will be withdrawn and whose family has given consent for organ donation in the controlled environment of the OR. So interestingly, as we mentioned today, the very first heart transplantation was actually a DCD donor. In other words, the donor was brought to the operating room, the groins were cannulated while she was still awake, and placed on the cardiopulmonary bypass as soon as the heart stopped. So there were no brain deaths at that time, and Dr. Barnard performed actually the very first DCD donor. So we are actually going back. For those of you who have seen the Back to the Future movie, we are gone to the Back to the Future now, going from those times where we see the DCD donor now to what we want to do again at this point in time. Last year, there was a paper that was published by our colleagues in Australia who have done over 14 DCD donors, and also in UK, they have done quite a few. So a total of 45 DCD donors with extremely tremendous result. 1 year survival of 91%, exactly the same as we achieve with our regular patients. So we are hoping that this would continue to grow and improve, and the technology has really helped us to do a DCD heart donors. So the question is, how can we do a DCD donor? As I said, the technology has improved to the point that we have a platform now that's called Ex Vivo Perfusion Organ Care System. The advantage of this kind of a platform technology is that we can avoid limitation of cold storage. We can continue to have the heart beating and perfusing while it's being transported, and we can potentially weed out the bad donors and increase our utilization of these organs. So the device itself is a portable device that you can see is a console that can be transported in the back of the SUV or a helicopter or a jet. It has a proprietary solution that uses to perfusing the heart. It has a module where the heart sits and actually continues to beat. And there's a wireless monitor where that's got a Bluetooth technology where we could take it in front next to the driver while the machine is in the back of the SUV and monitor and may change parameters while we are during the transport. So if you can, I don't know if you can play this or not. Let me see, go back again. Oh, here we go. Oops. So this is actually what the transported, and here's the donor. The aorta is cannulated. We drain about 1,500 cc of blood from the donor while the heart's still beating. So the donor becomes hypotensive during that time, and the machine is primed with about 1,500 cc of blood from the donor. Once this is done, obviously the aorta is cross-clamped, and then the organ is removed, and the organ is taken to the back table, and the aorta is trimmed, and then a cannula is placed in the aorta, and then it's secured in place with sutures and also with an umbilical tape and a tie bands to make sure this doesn't fall while the heart is being transported. Also, a cannula is placed in the pulmonary artery to drain the venous blood. And again, this is secured as well with a pursing suture or umbilical tape. This whole process of doing this on the back table takes about probably 20 to 25 minutes from the time the heart is harvested. So once this is done, the heart is brought out to the machine itself, and then the two are connected to the inflow and outflow of the machine, basically the arterial port and the venous port of the device. And the heart is actually, this is the back side of the heart. That's the module that I explained to you. That's all on the sterile condition. The pump already started. The blood is coming, and the coronary perfusion started as well. So the pump parameters are monitored during this time. The heart is reanimated. Sometimes we have to actually do shocks with small paddles that are connected in there. And the venous blood is then connected to the outflow part of a machine. We place a left ventricular vent through the left atrium into the left ventricle to get any air that may be there, and then we close the IVC. The SVC has already been suture ligated as well. So we can monitor the heart rate, we can monitor the coronary perfusion, and they can see the heart start beating after a few minutes of being perfused. So this is how the heart is being transported with this machine on, and continues to be beating while it's brought to the operating room at our own hospital. During this time, we measure parameters like lactate level, blood gases, venous blood gases, making sure the heart is getting perfused properly. We have cartridges that are available as well, and the device is then placed in the back of a SUV. And as I said, the wireless monitor is held by one of us while the transport is being done and adjusting the parameters. So with this kind of a platform, that's what the DCD donors can potentially be resuscitated. And we actually we were part of a very large study called PROCEED-2 trial, where we look at the perfusion of the donor heart in a randomized prospective fashion, multi-center study, and us and UCLA were the two major centers in terms of enrolling the highest number of patients. And using the non-inferiority study, we showed that using the organ care system versus standard of cold storage, the survival, the primary endpoint was 30-day patient graft survival was excellent. There was no difference between the two groups. So we think that the device would hopefully have a significant future in terms of technology and be able to expand our donor pool. Having experience with the OCS, we now going one step further and to the EXPAND trial, where we are hoping to be able to use this device in patients that are otherwise, or donors that otherwise are being turned down, like older donors, long distance travel, low ejection fraction, hypertrophied ventricle, coronary disease, and also other potential criteria. So in conclusion, I think the most important thing that we have to consider at this point is trying to decrease the gap between the demand of donor organs and supply. The technology continue to be innovating and getting better. And with the DCD donor now, we have an option for the families to patients with severe irreversible neurologic injury that are available to donate the donor the organs and not have to wait for the brain death to happen. We need to obviously establish some ethical and scientific goal and protocols to be able to achieve this in the future. Thank you very much.
Thank you so much for that. Technology has improved dramatically over the years. And what I'd like to do for the next few minutes is just talk about where we are in terms of the future of heart transplantation and where we are today. Let me start. Currently, the gold standard to detect heart transplant rejection has been the heart biopsy. Heart biopsy is resource intense. It's uncomfortable to the patient to have a catheter placed into the internal jugular vein. So why not use new technology in terms of the DNA of the donor? Let's think about it. When you receive a donor heart, the donor heart comes from somebody else. They have a different DNA from those of the recipient. So why not use that difference? Why not detect the DNA from the donor if there's injury to the donor? If there's injury, actually cells start to deteriorate, and you can actually have spillage of the donor DNA into the bloodstream. Can we detect that? And the answer is yes, we can. Now here's an example of what we call cell-free DNA, and this is found in the circulating blood. And when you think about it, all of us in this room are gastrointestinal tract cells. They actually, go into programmed cell death, and they die, and they release DNA. So there's actually a lot of DNA in your body that's free, that's in the bloodstream that you can actually measure. And so the DNA can be extracted from the blood sample, and there's a steady rate of about 6 nanograms per mil. And the higher levels will be increased, perhaps, with cell damage. And that's something we may see here. And in blue represents the normal cells that do have regular turnover. And then in green represents cells that are diseased. If they're diseased, you'll let off more DNA from the body. Now, what if you're having heart rejection? If you're having heart rejection, maybe we'll see more of this, meaning DNA from the donor that we can actually detect. Now, wouldn't that be actually something? Now, working with one of the groups in Northern California, we're able to actually detect donor DNA. I won't go through that in detail here, but basically this is looking at a certain number of genes to see where they're coming from, whether they're coming from the donor or from the recipient. So we did one of the first studies looking at cell-free DNA. And this is something from what we call the CARGO-2 trial, Cardiac Allograft Rejection Genome Observation Trial. And basically, we took 28 of these patients who had rejection and 17 that actually had blood tests before the rejection episodes. And we compared that to 26 patients who did not have rejection. And so for the very first time, we actually took a look at this. And this is what we found. In blue represents quiescence, mainly those patients without rejection. In red represents those patients with biopsy-proven rejection. And for the very first time, we see that indeed it's elevated. And we're actually detecting the donor DNA in higher levels. Now, you'll see a couple of points here that are elevated where there is no rejection, and I would submit that that's probably missed rejection on that side, where you actually have elevated amounts of cell-free DNA. And as it turns out, you can actually see that 26 to 150 days prior to the rejection episodes, 1 to 25 days, you can see a gradual increase. And so we can actually think about it that DNA, cell-free DNA, can actually predict when rejection may be occurring. And finally, what about therapy? Well, as it turns out here, these are some examples. You can see the cell-free DNA actually goes down very nicely as the rejection resolves. And so we think that we're onto something new here. We're actually looking at the big database that we now have with over 1,000 patients, 1,000 samples, and we'll be presenting that at the International Heart Transplant meetings in Nice later this year. Let me just go on. There's something called inflammation and cardiac allograft vasculopathy, which is one of the major problems limiting long-term survival. I won't go into this in detail, but what we think is that there is a molecule called interleukin-6. It's a widely pleiotropic cytokine, meaning it's a molecule that's involved in inflammation and involved in a lot of the problems of transplantation, rejection, not only acute rejection, but chronic rejection as well. And I just show you this slide here just to demonstrate that interleukin-6 is involved in many different pathways. And again, they're involved in rejection and proliferation, in antibodies development as well. Now, wouldn't it be something if we can actually knock down this interleukin-6? And as it turns out, the answer is yes. And in fact, in kidney transplantation, Stan Jordan and Ashley Vogt did that here at UCLA, at Cedars-Sinai in 2015, showing that blockade of the interleukin-6 molecule can actually decrease rejection. And so we are now starting this study here, future work to assess the efficacy of tocilizumab, which is a blockade for interleukin-6. And we actually are funded. We actually have a score of 3% for NIH grants. So we are being funded at this point. And this is a triad between Cedars-Sinai, the Harvard programs, and Mount Sinai in New York, where we put together a big randomized trial. 200 non-sensitized patients will be randomized to this new drug. And we believe that we may actually decrease rejection, decrease chronic rejection in terms of allograft vasculopathy, and decrease antibodies as well. Certainly may be a new paradigm shift in terms of transplantation for the future if we can actually knock down all of these inflammatory molecules. And I'd like to just end with a total artificial heart. Dr. Ismailian mentioned that very briefly, but over the past 30 years, this technology has improved in its design, safety, reliability, and utility as both a bridge to transplant and destination therapy. Now, Cedars-Sinai is actually one of the largest centers in the United States, placing over 85 total artificial hearts to date. Quite dramatic. And improvements in technology have included a reduction in size and portability as well. And this is what it actually looks like in this device here. It actually takes the place of the human heart. So we've come a long ways in terms of what we can do here at Cedars-Sinai, and Dr. Marban with his stem cell therapy. Only at Cedars-Sinai will we be able to offer heart transplantation, the total artificial heart technology, or even stem cell therapy. Certainly for the future, we have a bright future to look at. Thank you so much for your attention. So we do have a surprise guest, and transplantation is more than slides, more than the people that are here supporting transplantation. It's about our patients, about our patients who truly struggle and have that fortitude and strength to undergo transplantation. Now, I want to bring up Kelly Perkins. Kelly, come on up here. I just want to tell a little bit about Kelly. Kelly was transplanted in 1996, I believe. 95, I was off 1 year. And she had disease where she had cardiomyopathy and was having irregular heartbeats. She underwent heart transplantation, but the story doesn't end just there. She had a lot of rejection episodes.
A lot of rejection.
And we had to treat her with some experimental therapies, photophoresis. And it's something that was really not done before. And by golly, it worked. Well, let me have Kelly tell her story from there. Kelly, please.
Thank you. Of course, Dr. John, thanks. So put the medical dictionaries away. And I'm just going to take you back to 2005. So picture this. It's the middle of the night, and I have to go pee. Okay, so many of us in the middle of the night have to go pee, not so remarkable. But again, picture this. I am dangling off of a rope the size of my finger with 2,000 feet of vertical space below me. Never in a million years did I think I would be climbing one of the world's largest rock walls. But never in a billion years did I think I'd be doing it with somebody else's heart. So this is my story and kind of how I got here in 9 minutes. So bear with me. So just taking you back, a little background. I met my husband here in college and up in the Bay Area. And one thing we used to do is every weekend, any chance we got, we went to the mountains. So we went backpacking or just hiking. Now, typically, you would just put on your boots and go hiking. But I liked adventure. Adventure made me feel alive. So I had the city boy, he was from San Francisco, I was from the mountains. I had to take him for a test drive. So I had him strap on some ski boots, or some skis, and we went to find the last remaining snow up in the mountains, midsummer. And we did. So he was cut out for the job, I could tell. So fast forward to our 5-year wedding anniversary. We decided to take some time and just go travel through Europe with a backpack, a small backpack, and no reservations. Just life was free, it was simple, it was easy, it was what it should be when you're 30 years old. So this is an important picture because, you know, we're not in the time of Facebook and your cell phones taking photos. When you took a photo back then, it was something you wanted to remember. This is important because it's the last photo I have when I was 100% healthy. When I came back from this trip, I had noticed that my body was feeling different. And again, I was an athlete. I was in touch with my body. So I knew my normal resting heart rate was about 50 beats per minute. But things weren't feeling right. So I went to the doctor. I was sitting on the examination table, and he did an EKG, and my resting heart rate was 4 times my normal rate. So we knew something was wrong. However, no history of heart disease in my family. I am healthy. There had to be a pill or something that I could take and I would be 100% okay again, right? Not so easy. Turned out I had viral cardiomyopathy. So over the course of the next 3 years, I did whatever I could to take care of myself, to stay strong. I was on 28 pills a day at one point in time. I had implants, of course not these kind, but I had every kind of implant you can imagine. You couldn't put an old device with experimental lead wires, and I ran out of battery life, pacemaker infections. I had it all. Finally, at the 3-year mark, my body was done. I had nothing left. So that's when finally I was fortunate enough to get a heart. Well, as soon as I got a heart, of course, Dr. John talked about rejection. I went through that. He brought out his cutting-edge tools, and we were able to get beyond that. But for me, I wanted to get back to the mountains, what I loved, rebuild my body, my strength, my mind, get away from being a patient. I wanted to be Kelly again. Because when you're in this medical world for so long as a patient, you're labeled that way, and you start seeing yourself that way. And so people are always asking me, how are you feeling? I didn't want that. That wasn't the kind of life I wanted to live. So I chose to go hike a mountain to regain my self-image. Talked to Dr. John about this. No idea. So we were thinking, let's just go. This is Huff Dome in Yosemite Valley. It's a 17-mile round-trip hike. And my husband and I were thinking, let's just go as far as we can. If we want to turn around, we'll turn around. Great. Well, I actually made it to the top. And here we are peering over the edge. And it was such an amazing thing to be. I felt I was back again. And we're peering over the edge, and we see these little white helmets coming up, and there's these climbers scaling the face, and we're like, oh my God, that looks so fun. But after being up there for like 10 minutes, you realize you're only halfway there. We still have a ways to get back down. So we made our way down, and that's when trouble happened. And I ran out of fluid, and I became dehydrated. Now, we weren't out there recklessly just going for a hike with no, I mean, we brought what we needed, but my body was different. You know, the medications they just made my body behave just not the same. So I ended up in the hospital, I came back, everything was fine, it was simple dehydration. But, you know, it was hard because everyone's kind of beating us up, like, that's so reckless of you. You get this beautiful gift, a brand new heart, and what you're risking it didn't seem responsible. But that wasn't good enough for me. I'm not one to be okay with that. So I picked another mountain, a bigger mountain. Now this is in the Central Valley, Mount Whitney, and it is 14,000 feet. And the reason why I chose this is because I had done this mountain, I had climbed this mountain with my native heart. So I thought this would be a direct comparison of my new heart versus my native. And here I am on our way up, and actually made it to the summit, which was great to be able to stand there and have this, to be able to do it with two separate hearts. I did it differently. I took more time. I didn't carry the same amount of weight, but I made it. So after this, I wanted to do something more remarkable, and this was right around the millennium. And so I wanted to go back to Africa, to where the very first heart transplant took place, and to climb their highest mountain, which is Mount Kilimanjaro. So we set over to do this. We took the longest route, taking extra time to acclimatize, to be safe about it. And, beautiful scenery, but we spent days and days trekking. And as much as I could look at everything going on outside of me, I had to pay attention to my heart rate, my pulse, my oxygen levels, everything. My blood pressure was all over the board, so a lot going on. We brought this as a backup. It's called a Gamma bag. So in the case that I was having altitude issues, I could get into this little thing, and it mimics a lower elevation. So that would be my safety net. So the last day was just horrendous. You have a classic alpine start, which is 1 a.m. in the morning. It's freezing cold, and I'm still kind of little, and these winds, and I have this big down jacket on. It was quite fierce, but I did make it to the rim. Got to the rim, and I'm all excited, turn around, and there my husband is on the ground. And he had altitude sickness, so he had to go back down. So he encouraged me to keep going, and I did. And here I am standing at the summit of Mount Kilimanjaro. Now, again, when we think of that first recipient that lived 18 days, and here I am 6 years post-transplant on the top of Kilimanjaro, that I think is really remarkable. So after this, I kind of, my style by now. I keep setting new goals. And let me go back, I'm sorry. But after Mount Kilimanjaro, we went and we visited the hospital. I'm not going to pronounce it, because I'll butcher it. But we were supposed to meet Dr. Barnard, but he had actually passed away a month before we got there. So we visited the museum, which was daunting, this equipment. Talk about progress, thank you. And I actually met with his daughter, which was nice. She was representing her dad, and so we had a nice little meeting. But after this is when I wanted to get into some more technical climbing. And remember those little white helmets I saw coming up? I had that goal in mind. So we trained all over the place and just traveled and did what we could to learn skills, to perfect the skills. Because this, again, going back to Half Dome. Now, what moves me about this mountain is, if you look at it, it's broken, but it still stands tall. I think there's such a strong message there that we don't have to be 100%. And for me, it was a big motivator. And so in doing this technical climb, this is the route. Before we had come up on the backside, but now we were going to scale the front. And we took 2 days, we went 2 days on the wall, 2 nights on the wall, and it was just a classic climb. And, as much as there's a lot going on when you're climbing a wall like this, you've got ropes, you've got gear, you've got harnesses, you've got things that you do. You're pretty busy doing it. But I had to still pay attention to what was going on, just like I was when I was hiking everything else. That's an ongoing thing. I'm not who I used to be, but I'm doing what I used to do, even better, with more appreciation. So having fun, and when we got to the top and we're topping out, we had some friends that were up top that had arranged for people who were just climbing Half Dome. It's a very popular place. They get up to 500 people a day in the summertime peeking out at the top, climbing up the backside like we did the first time. And I had friends handing out T-shirts for anybody who wanted to hang out and wait for us to come up over the rim. And they did. So when we got up, we looked over, and there were over 150 people from all over the world who had stood in their red T-shirts in the shape of a heart. And we had a friend who is from Spain. You're not supposed to fly very close to Half Dome, but she pretended like she didn't speak English and kept telling the pilot, go over there. She's really pretty, so she gets her way with doing things. And so she actually captured a photo of us from above. And so you can see these are all these people. It's people standing there in the shape of a heart. I think it's such a sweet thing. So anyway, with that, I, of course, would not be here without all of, Dr. Barnard, the first donor, the first recipient, and all those little things and big things that happen along the way. I'm so grateful. I'm grateful for all that you do each and every day, and it does matter for people like me. So thank you.
Fantastic, Kelly. And not that all transplant patients climb to the top of Kilimanjaro, but certainly it's a great recognition. So we'd like to finally end with words from Dr. Shlomo Melman, our academic dean, who will tell us about his experience in South Africa as well. Shlomo, please.
Before I do that, I just wanted to congratulate the entire transplant team in the room, and John, and where are all your surgical colleagues? Oh. All over there. Yeah. Hi, guys. Congratulations to all of you.
Yeah.
And Kelly, Louis Washkansky's smile, those were the headlines of the Cape Town newspaper, the Cape Times, in December that morning. His smile is transmitted to you and to all your colleagues, so thank you, Kelly. And this is what doctors do. They bring smiles to patients. If you go to the museum that Kelly spoke about in Groote Schuur Hospital, there are really three heroes: Louis Washkansky, who we're celebrating, Denise Dorval, the donor, and, of course, Chris Barnard. And here he is the morning after, a couple of hours after the surgery, meeting Dr. Barnard, and we've all seen the operating report. And here is the time which has been recaptured in the museum in Cape Town in the exact same operating room that the transplant occurred, 5:57 a.m. on that wonderful morning. And Kelly, you're a testament to those 50 years since that time, 5:57 in the morning. But if you look at his heart, look over here on the left, this is Washkansky's heart with a huge, huge hypertrophy, and this is the donor heart, which unfortunately had to be removed within 2 weeks after the operation. And you can see the remarkable differences in the two hearts, which are still present in the museum. In Barnard's office, which has been kept intact, he has this photograph of wine, women, and smoking. This was his life, and this is a meeting he had with Golda Meir, and you can see over here, this is not a role model for medical students, or certainly not for patients. He's with a woman, he's smoking, and he's drinking. And of course, we're all here to celebrate all the good work that came out of this wonderful institution. There are many graduates in the room, and so we are celebrating the history. We're celebrating Kelly and all her colleagues, and all the colleagues who we're going to be treating in the future all came out of Groote Schuur Hospital 50 years ago. Thank you, everybody, and thanks for a remarkable program.